Hello, everyone. Welcome to our February signature series. We are really excited to have three very special guests joining us today. Dr. Allen, Dr. Rush Wilson, and Jason from ANAD, one of our partner organizations. We're really excited to have all three of you here to talk to us today about eating disorders and nutrition. And I'll let you guys introduce yourself and tell us a little bit more about all the amazing stuff that you guys do. And yeah, I'm really excited to hear your presentation. Thanks again for being here.
Thank you.
Awesome. Thanks, Kelsey. I will go ahead, share my screen, and we can kind of dive into some of these introductions. Let's see. I think first up, we got Dr. Mark Allen. Would you like to go ahead and introduce yourself?
Yeah, sure. Hey, everybody. Awesome to meet y'all. Love the Hidden Opponent. Been involved with the organization now for a couple of years. Leanne and I actually went to the same college, just I'm a lot older than she is. Anyway, I'm a sports psychiatrist based out of Denver, Colorado, and most of my passion lies in helping collegiate athletic departments as well as college students with transitions and whatnot. But eating disorders tend to be really close to my heart. I've been working in the eating disorder field for 15 years and ran a remote clinic in Maine for a long time, but then I was the medical director of a eating disorder and sport program here in Denver before now, just doing private practice work. So anyway, I will stop talking. This is definitely Jason and Tiffany's show. So
We couldn't do it without you. I'll pass it off to Dr. Tiffany Rush Wilson to introduce yourself.
I'm Tiffany Rush Wilson. I do a couple of different things. Monday is the day that I do all three of my jobs. So I am the program chair for a graduate program in counseling. I am a psychologist who works with a professional sports team and also some high performing artists. And then I have a private practice. I've been doing eating disorders work since my internship in my master's program. So for a little bit more than 20 years. So I've been doing this a lot, and I specialize sometimes in what are considered atypical patients in eating disorders. So people of color, men, people of different socioeconomic status, those types of things, just other human beings who have eating disorders.
All right, thanks so much. And then I'm Jason Wood. I'm an eating disorder survivor turned advocate. So, like Tiffany was just saying, men can get eating disorders too. That's often a surprise for people. I know it was a surprise for me. I wrote my book Starving for Survival a couple years ago, just talking about my experience with orthorexia and my battle with an eating disorder. Now I have the awesome opportunity to be the director of community engagement at ANID. We'll talk a little bit more about that or our organization at the end. But I'm also on the board for Michigan Eating Disorders Alliance, Running in Silence, which is an amazing nonprofit, especially for runners and track athletes, and then Soul Pause Recovery Project. And I am really excited for the opportunity to get to join you all tonight for this conversation. So I kind of wanted to kick it off with a question. So feel free to post in the chat. But what's something that you know about eating disorders? Maybe what's something you've heard, something you learned about in school. Just kind of curious what your first thoughts are when you hear the term eating disorders. All right, I like that right off the bat. They can affect anyone, so you don't even need us now. Like we've already got the plan down. That's a great one. Yeah, trouble with eating too much or too little. Yep, about control and fear. Oh, that's a big one. Can't always be seen. Yeah, awesome. Yeah, you cannot just tell someone has an eating disorder. So these are all great responses in the chat. And yes, and common in athletes, unfortunately. Yes, we see a high prevalence there. So I think one of the biggest things as we're getting close to Eating Disorders Awareness Week here at the end of the month is it's always a great opportunity to maybe dismiss some of the stereotypes or the misconceptions around eating disorders. And I think tonight we'll really dive into that a little bit more and look at it from the full picture so that you can really understand maybe what are some of those stereotypes you might run into at campus or in your communities, and maybe how you can address and navigate some of those conversations. All right, so I will pass it over to Tiffany to talk a little bit more about what an eating disorder actually is.
Yes, so eating disorders are super complex. So as the slide notes here, complex mental health illnesses, where people experience severe disturbances in their eating behaviors and related thoughts and emotions and engagement, how they relate to food. They have the second highest mortality rate among mental health conditions, and there are several eating disorders to be aware of. If you don't mind, Jason, I'll just go through what we call an eating disorder according to the Diagnostic and Statistical Manual that the American Psychiatric Association puts out. First one,
Absolutely.
the one that has gotten the most research and publicity over time has been anorexia nervosa, which is when people eat very little food. They tend to have low body weight, have a strong fear about gaining weight, often negative thoughts about their body shape, their size. That one's been around even with its current name since the late 1800s. So we know quite a bit about aspects of anorexia nervosa. Then in 1987 or so, anorexia nervosa spun off because some researchers thought, hey, there's something weird about this particular subtype, this binge purge type of anorexia nervosa, where in some patients, their body weight's about the same and it's about normal weight, quote unquote. That one's now called bulimia nervosa. Repeated episodes of eating large amounts of food that's followed by behavior that's called inappropriate compensatory behavior, or people do something to undo what they've eaten. So that purging, as it's called, can be purging by vomiting, purging by some other means of getting rid of or eliminating the food, laxative use, exercising too much. Then we have binge eating disorder, which was relatively recently acknowledged as a full, distinct eating disorder. It is identified by repeated episodes of eating large amounts of food or what someone believes to be a large amount of food without trying to get rid of it afterwards or without trying to purge the food afterwards. And often the person who eats this way feels really bad about how they're eating. There's one called ARFID, ARFID, which means avoided restrictive food intake disorder. This person eats very limited amounts of food because they might have some sensory engagement that feels kind of weird. They don't like the texture of the food. I know somebody who really didn't like foods of certain colors. They might fear choking or vomiting or just all kinds of things that lead them to have sometimes a lower interest in eating the food, but they don't often have body image concerns. We got pica. That's the one where people eat food or eat things that aren't food. They might eat paper or chalk or sometimes soil and other things that aren't food. There's not a nutritive value to what they're eating. Couple more here. Rumination disorder. This person will eat and they repeatedly bring back up the food they're eating, and then they may re-chew it and re-swallow it. Sometimes they do actually spit it out. We have the one that's not actually in the DSM, but it shows up a lot, called orthorexia nervosa. And one of the things I didn't do is talk about the actual meaning of the words. The word anorexia means lack of hunger. Nervosa means due to nerves. Bulimia means ox hunger. Nervosa still means due to nerves. With orthorexia nervosa, we're looking at pure clean eating due to nerves. And this is an unhealthy obsession with eating foods that the person identifies as pure, as clean, as healthy. And they have really strict rules sometimes about how they engage food, what they'll allow themselves to eat, and can feel really bad or guilty if they don't adhere to the rules that they've set up around eating. That one is not technically in the DSM, but it's something that may show up clinically. And then we have OSFED. These are other specified feeding or eating disorders. And these are things that don't exactly fit into the DSM, but they have clinical symptomology. One is atypical anorexia nervosa, where all of the criteria for anorexia nervosa may be met, but the person's weight is not clinically considered too low. Low frequency bulimia. Did someone have a question? Low frequency bulimia nervosa. That person might not purge the number of times that are required to meet criteria according to the Diagnostic and Statistical Manual, but this is still a problem. Binge eating disorder, with low frequency, so they might not binge as frequently as the criteria identify. Purging disorder, this person purges without binging, and then night eating syndrome. A person may have unusual night eating patterns. For instance, I had a client who, two I can think of, one who ate lots of meals and typically pasta for her after she'd already eaten meals, and another one who ate peanut butter late at night, constantly, whole jars of peanut butter at a time. And then finally, we have UFED, which is unspecified feeding or eating disorders. And that's a feeding or eating symptom that causes problems and impairment, but they don't quite meet the specific diagnostic criteria. That's all that we have.
All right. Thanks, Tiffany.
You're welcome.
So another question that we will pop here in the chat, and then Dr. Allen will have the answers for us. But what are 5 sports that have the highest risk of developing an eating disorder? Let's see how many of these you can name. Running, cross country, swimming, gymnastics, dance, wrestling. All right, so we're seeing quite a few different sports shared here. So, Mark, would you like to go ahead and share with us what those top 5 actually are?
Absolutely. So first off, I just want to say in the comments, like y'all crushed like what eating disorders are, and as far as
Yeah.
they are not about food, they're about control, and they're invisible and blameless illnesses. And so you really can't see just a person walking along the street, whether or not they have an eating disorder, and they can affect all kinds of people, all cultures. There's actually a famous study done in the island of Fiji that pre-1990s, there really weren't any known eating disorders on that entire island. Now, mind you, they weren't really studying for it. But then with the advent of cable television that came in, within a few years, the rate or prevalence rate of eating disorders in that country matched the Western world. So there clearly is a socio-cultural element to this as well, versus it just being, a biological illness or psychological illness, social illness. And we'll kind of talk about that in a little bit. So it can come from all sources. As far as this, because we all like sports here, we're here to talk about sports. The sports that have a higher prevalence rate of eating disorders kind of are in basically 3 categories. One is where lameness is sort of benefits that sport, so endurance sports. Another are weight-based sports where you actually have to put like a square peg in a round hole, like for body. Does your body phenotype match what the sport needs for that quote weight class? Noticing I'm just calling it a weight class. That doesn't mean that that's necessarily what the person should have. And finally, the last category is appearance-based sports or aesthetic sports. So that's where a person's actually getting judged by how they look in competition. And so if you think about those 3 categories, that would probably then pop up with what sports there are. So y'all kind of nailed what's on there. So do we actually have the 5 that are coming up in drop down form?
No, so we've just got the pictures. Yeah.
Okay. Well, so anyway, first being rowing is definitely there. Gymnastics, figure skating, cycling, and cross country running. Specifically, women's cross country has a very high rate of both anorexia as well as depression. That's actually the highest co-occurring rate of depression within eating disorders. Cycling, as you might imagine, is a leaning sport where it actually benefits that. I don't know if anybody remembers the story of Lance Armstrong. Okay, obviously he did some terrible things, but in his book, it's not about the bike. He actually talks about how his body changed when he got cancer. He went from being a sprinter to a long distance endurance runner. He started, or cyclist, and he actually started winning the Tour de France rather than just stages. He attributes that to the weight loss and his body changing from having had the cancer. So that actually shows you like kind of how that benefits that sport. As far as the prevalence in female athletes, we'll just kind of move along because we have a lot of ground to cover here. Roughly a third of elite athletes report an eating disorder. And really, disordered eating, which is where there's a difference between full-blown eating disorder and maladaptive eating, that's a much higher rate. But lean sports, we're looking at nearly half, 20% in non-lean sports, roughly 7% of US collegiate athletes are reporting. Of course, this is what's reported. It's obviously, I think, going to be a lot higher than that. And then sport type, you have the appearance-based or aesthetic sports have the highest rate, then endurance, technical, and then ball sports. For male athletes, as Jason was mentioning, that can happen to them to all genders. They tend to have a much higher rate of eating disorders versus non-athlete males. Of course, again, it all comes down to stigma and who's reporting. But anti-gravitational sports, think about like rings, gymnastics, that kind of thing. It's very high weight class sports. I think wrestling, my guess is that it's incredibly high rate there. I don't actually know a wrestler that I've ever met, at least in clinic, that didn't have some sort of disordered eating element to sort of cut weight. Same with like ultimate fighting, those kinds of combat sports where you're trying to meet a weight class. It is not normal to about 12 pounds of just water weight in, very short period of time. There's something wrong with that. I also work in jockey mental health. And so within the horse racing business, it is not crazy to hear that a jockey has gained and lost up to 5,000 pounds in a year based on the kind of stuff that they need to do for their job. Again, I think we need to change the set point that's required in that sport. But yeah, weight class sports are very high. Endurance sports are high prevalence, as well as ball sports. And then rowers specifically is a population that I think is really important because there's actually a person on the boat, a coxswain, that doesn't actually even row, and is the entire purpose of that person being on the boat is to actually like keep everybody in cadence. But they're judged based on their weight. They can't be on the boat unless they weigh a certain amount. And so that disordered eating within that population is off the charts. So we kind of talked about the biopsychosocial factors, of which you can't, blame this on the parents or anything like that. In fact, it's unhelpful in recovery, in treatment. When someone comes to my clinic and they have a clear eating disorder, we absolve any guilt from anybody that comes in the room about where that came from. Actually, causality is unhelpful in that moment. Once someone's weight restored, then we can start talking about all the elements that led us to that position. But all hands on deck. We need to like get to like if you think about it, a child. We're going to talk about it, kids. When you think about family-based therapy, you need to activate the family system, the sports family around that person to all hands on deck to feed that starving kid, to help with weight restoration, because that does really require a village. Psychological aspects, this has been not about food, it's about control. And so you're needing to introduce new ways to deal with stress rather than the things that they've been leaning on, which are maladaptive, restricting their eating, over exercising, binging, purging, all of those kinds of things, which erupt as ways to deal with that stress. And finally, social, it can spread like wildfire. So within teams, there's actually sometimes competitive thinness or competitive body appearance. And so there's unhelpful things about the culture that can be shared that can lead to the development of disordered eating symptoms. And I'll pause. Someone else talk.
All right. Did you want to take this one, Tiffany?
Sure, there is an increased risk for eating disorders among, as Dr. Allen already said, among athletes or anyone who has kind of a performance emphasis or an emphasis on their physical bodies. So sports don't cause, but can increase the risk. Sport-specific pressure, perfectionism, cultural and coach influence, which I see a lot in clients, overtraining and food restrictions, body dissatisfaction, just putting a lot of pressure on oneself to be perfect in whatever capacity that they are performing. One of the people who has one of the most intense eating disorders, who I'm working with currently, is actually a ballet dancer. And while that person doesn't consider themselves an athlete per se, they train really hard and they are a performer, and their physical body is the focus of their career. So lots of these people who do like athletics or very beautiful things that we might admire, might have an inner turmoil to make sure they meet the standards that they believe they should meet and what they believe other people expect of them.
Yeah. And then this was one of the best lines we heard. I put it in there for you, Tiffany.
Thank you much. So I often tell people with whom I work that the only requirement for an eating disorder is that you have a mouth. If you have a mouth, you can be susceptible to an eating disorder. It's not based solely on your race or on your sex or on your height or any human being, any person can have an eating disorder. And that comes in part from the fact that for many years, there's a very narrow focus group of people who were researched for eating disorders. So we learned a whole lot about a very limited population or a limited group of people who had problematic eating. But eating disorders are coping mechanisms. And if you are human, there's probably something with which you've had to cope. So people of different sexes, religions, ages. I remember my first client who was 60 with an eating disorder when I was an intern many years ago, and being a little bit surprised that I had never actually been prepared to work with a person in this particular decade of life, and had to go back and research and find out what do we even know about people in this particular decade with eating disorders, because it wasn't a focus. So if you have a mouth, you can have an eating disorder, and we have to be very much aware that there is a lot of mythology around who can qualify for the eating disorder club, so to speak, facetiously, and who's left out. Any person can be someone who needs support.
Yeah, and that one person was me. I did not think that it could happen to me, based upon what I had learned in school, what I had seen in the media. I wasn't concerned about an eating disorder, so I had this unhealthy relationship that was starting with food and exercise, and I just thought it was normal because that's just what people do when they want to take care of themselves and perform in sport. And as a guy, I was like, well, that's not a problem. That's not going to happen to me. But the truth is, there were a lot of contributing factors that were playing a role in the development of my eating disorder. And it really goes back to when I was a kid. I was in a larger body at that point. I was picked on. I was bullied in school. So that made me very insecure at a young age, very hypersensitive about what my body looked like, and feeling like other people were judging me based upon my appearance. So then come high school, that's when I had that first introduction into formalized dieting. I had joined Weight Watchers and immediately clung to it. I wanted to be the perfect dieter. I wanted to be as good as I could at counting calories, at watching macros. I wanted to be the best performer in the gym. I just wanted to be the best at everything, and there was this driving need for perfection. I also experienced a lot of trauma. I had lost both of my parents in my teenage years to cancer. My dad passed away when I was 11. My mom passed away when I was 19. And losing both of them at that age really sent my life into a tailspin. Suddenly, everything that I knew, my safety net, my security, it was all gone. So I was clinging for something to try to cope with all of this. So I turned again to that disordered relationship that I had already established with food and exercise. And I was like, okay, I can't control anything else, but at least maybe I can control this. I can control what I'm putting in my body. I can control what I'm doing with my body. And I clung to that through some very difficult times. Along with those difficult times, it was easy to feel like a failure. As somebody who's always been a perfectionist, in school, I had to have straight A's and be on the super honor roll and be a part of all the clubs and all of this. To be in my early 20s and to feel like I've fallen flat on my face, because at that point I'd also fallen into drugs and alcohol as a way to try to cope with everything. I was just in a lot of pain overall. I had a big falling out with my family, and it was easy to feel like a failure. So I was like, well, I'm not good at anything else, but at least I'm going to be good at diet and exercise. I'm going to be good at that time I was playing tennis. I was like, I'm going to be the best tennis player that I possibly can be. And it was all of those things that I was trying to focus in on while it just felt like I was failing at adulthood. And then the last thing there that's part of this like perfect storm that developed into my eating disorder was a health scare. At age 29, I started to exhibit some of the same symptoms that my dad did when he was diagnosed with colorectal cancer. Went to the doctor, had a colonoscopy done, and they found three polyps that were very close to turning cancerous. And that was terrifying for me to be 29 years old and be facing what I thought was like this old man's disease, something that I wouldn't have to worry about for many, many years. So I wanted to control the situation again. And that is really when I doubled down and went into that full-blown slippery slope into orthorexia, where I had to eat as clean as I possibly could, where it was very much focused in on the quality of the food rather than the quantity of the food. And all of these different things played a contributing factor. I can't go back and say this exact one is the exact reason why I developed an eating disorder. It was a combination of all of these things. It's kind of like what Dr. Allen was just talking about with the social, the psychological, and the biological. It was a perfect storm that really developed, and unfortunately, it manifested into an eating disorder that I would end up battling for about 20 years.
Jason,
So,
before
oh,
you continue, can I add one additional thing?
yeah, go for
First,
it.
thank you for sharing that piece with all of us. It's
Hmm.
important to also keep in mind that when someone has really high standards for themselves, they might be perfectionists, they sometimes don't recognize their behavior as symptomatic or something that needs treatment. So that's important. And then also sometimes clinicians also don't recognize the symptoms as eating disorder worthy or eating disorder like if the person is male or if the person is of a different race or a person might be in poverty or whatever is going on with that person. So thank you for sharing that. Those types of misunderstandings can actually delay treatment. So I really appreciate you
Absolutely.
sharing.
Absolutely. Yeah, thank you for pointing that out too, because it was one of those things where I would go into my doctor's appointments and get praised and applauded for what I was doing. My friends, my family would say, "Oh, I wish I had the dedication you had. I wish I have the discipline that you have." And it was building me up, it was playing on those insecurities, made me feel really good. Never in a million years did I think it was actually creating harm until unfortunately I slammed into rock bottom. Yeah. All right. So we'll play a quick game here because I saw how knowledgeable all of you are with the chat. But just a couple of myths and facts around eating disorders. So this first one here, we've already covered this one. I saw it in the chat, but you can tell someone has an eating disorder by looking at them. Totally a myth. There we go. Everybody's posting it. The statistics actually show that less than 6% of individuals diagnosed with an eating disorder are medically considered underweight. So you definitely cannot tell by looking at someone. Eating disorders only happen to young, thin, white women. Again, a lot of myths, because that is not true. They can happen to anyone. Eating disorders do not discriminate. One thing that Tiffany was pointing out too is that eating disorders can happen at any stage in life too. And I think that's one of them that often gets overlooked. I was 35 when I was diagnosed with my eating disorder. And when I started to look around, a lot of the people around me were much younger. So I kind of felt like the old guy at the time. But now I see it in our support groups here at ANID where I will have individuals who are starting at, 16 all the way up to 60, 70 years old. So it really can happen at any age. This one we covered, but there are definitely more than two types of eating disorders, not just anorexia and bulimia. That was one of the things that also delayed my treatment for so long because I thought, well, I'm not restricting and I'm not participating in any compensatory behaviors, so I can't be dealing with an eating disorder. But the truth is, there are many different types of eating disorders. And above all, one of the things that I hope everybody takes away from this, and it's one of the things I'll be pointing out a lot during Eating Disorders Week at ANID, is there's no such thing as not sick enough. If you're dealing with any type of food or body image concerns that are impacting your life at all, talk to somebody. And then we already kind of touched upon all of the different types. I don't know, Mark or Tiffany, do you have anything else that you'd want to add to this slide?
There's one thing I do want to make sure people are aware of. There are a few on here that are not in the DSM or the Diagnostic and Statistical Manual that we use to diagnose eating disorders. Orthorexia nervosa, I already discussed. Drunkorexia and diabulimia really have to do with people manipulating alcohol and substituting it for, not substituting it for food, but drinking and using those calories sometimes as their primary calories in a day. unfortunately. And diabulimia is the manipulation of insulin sometimes with the purpose of trying to adjust weight and lose weight. Those can be dangerous, they can be debilitating, they can be life-threatening. Mark, I'm not sure what else you'd like to add, if anything.
Oh, that's good. It's it really is important if you see someone that's struggling with the relationship with food and body image. It's less important about the labels, more important to get them help. But there are a lot of things that are listed that aren't necessarily in the DSM, but that are are agreed upon that are problematic. That can lead to all kinds of issues medically, which we're going to get into very shortly. But yeah, so someone's talking about how they're saving their calories for to go out at night and just to drink themselves silly or whatever. But when they're not actually eating anything all day, water intake being extremely poor, being on the verge of passing out, like all that stuff, it needs to be addressed. So, student counseling, we should take them there.
All right. And then did you want to dive into some of the
Yeah,
common
let's do
warning
it.
signs?
This particular slide, it might seem a little dense. What the takeaway here is that eating disorders can affect every single body system. It's from just generic that it can lead to problems with fatigue and difficulties with regulating temperature to actually oral and dental health. In fact, dentists are typically the first people to recognize when someone has purging because they'll notice enamel decay. And if you might notice that there's sometimes parotid gland enlargement on the sides of someone's face when they've been purging because that kind of gets overactive, and then actually can actually lead to further body image distress as they feel like their face is enlarged or fat, but it's actually just due to the purging that's existed. The only way for that to go down is with cold packs and to stop purging. GI stuff, you can imagine it can just be a mess. When someone stops eating or restricting their food, their GI system slows down. That can lead to something called gastroparesis, which can feel very uncomfortable. You're prone to bloating, as well as constipation. And so that then it feels like then you're full. And then it's just a perpetuating cycle. Endocrine, it's a mess, especially when someone's biologically female. If you're losing your menses due to because you don't actually have enough body fat in your body to be able to have correct female reproductive system, that's not good. It can lead to loss of bone health as a result, as well as fertility issues. It keeps going. I mean, mental health issues, all kinds of co-occurring diagnoses that can go along with eating disorders. As I was saying, they're about it's lots about controlling food, but very, very high rates of depression and anxiety and OCD. But you can have problems with memory, as you might imagine, if when a starved brain is not a healthy brain. Um, Cardiovascular is probably the one that's most recognized when people think about like anorexia, like, oh, well, yeah, can't that lead to heart problems? Absolutely, it can lead to arrhythmias. It can lead to floppy valves. It can lead to very weak heart. All of that is not a good recipe for a heart that's working well. And actually, that's the highest risk for that is actually cardiac failure. Um, Musculoskeletal, as I mentioned, having some bone loss. I've seen patients that come into my office who've been restricting for a very long time, have lost their period, and actually have a DEXA scan, which is basically a very complicated X-ray that looks at the density of bones. And a 20-year-old female could look like a 75-year-old female on their bone scan. And so that's like tangible data. A lot of folks with eating disorders like numbers and like raw objective ways of approaching things. It's sometimes one of your ways in. Although, please understand when you're talking to a patient with an eating disorder, the eating disorder doesn't want to hear. So it's very important to externalize the disorder from the person. The person wants to recover, the eating disorder does not. And so, even though you're showing them very clear cut physical data that's going on with their body, eating disorder is irrational person isn't. In fact, then but you're trying to engage and ally yourself with them to then battle against the eating disorder that they're dealing with. Finally, you'll notice some skin changes where your body, when it's really cold, actually develops the growth of small little hairs called lanugo to sort of create a little blanket. And then genitourinary and renal, you'll notice they can develop electrolyte disturbances from purging. It can be extremely dangerous and lead to cardiac arrhythmias and stuff. And then anyway, the list goes on, but it's real. But what not mentioned in here, obviously, this is just the physical complaints, with the invisible mental health issues that can erupt as well.
Yeah. And again, kind of just an extra note there on orthorexia, touching upon my story a little bit. It's not a formal diagnosis, but it is one of those that still needs to be deserving of attention. And one of the studies that I found recently is between 21 to 41% of athletes are experiencing some form of orthorexia. And like we said, it's easy to miss, especially in a culture where diet culture reigns supreme. It's everywhere we go. Yesterday during the Super Bowl, I was watching commercials that were feeding right into this diet culture rhetoric, and it normalizes it. So those of us that are battling orthorexia often feel justified or validated in what we're doing and don't realize how serious of an impact it could have on our lives. Some of the warning signs for me, because this is a question that I get a lot, is where did it go from just this healthy desire to want to take care of myself, to be in good shape, to do all the right things? When did it cross the line and become fully disordered? When did it become that eating disorder? And these are some of the different examples that come to mind for me. The first one being lost hours. I was spending hours upon hours researching nutritional information, researching health food blogs, following influencers on social media. When I would go on vacation somewhere, I would have to make a detailed list of all of the restaurants and then pull up their menus and search those menus to identify what I thought was going to be the healthiest options on the menu. So, needless to say, I was not a very fun person to go on vacation with at that point, but it just shows you how much time I was starting to spend on this. That can lead to a lot of isolation. So can canceling plans with friends or avoiding social gatherings because I didn't want to break any of these food rules. So I started to become very isolated. There were no rest days. I was going to the gym every single day, sometimes multiple times a day. So a rest day, even when I was sick, even if something else was going on, it was always like the gym would take the priority and everything else could just get pushed to the side. I was living in a place I like to refer to as healthified hell. I can characterize that with a cauliflower crust pizza because I'm not celiac. I don't have to be gluten free, but I had seen in all the health food blogs that that was the way to go. So I convinced my husband to make this cauliflower crust pizza one time, and it takes a long time to make one of those from scratch, by the way. So he like worked on it all afternoon. I took one bite and it was horrible, but I convinced myself that this is just what pizza is going to be from now on. This is the healthy way to be, so I'm just going to continue to eat it. And the same would be said for a lot of other foods that are out there. You can substitute and swap in ingredients left and right these days that are healthier for you or better for you. But oftentimes it's not what you want, and it doesn't really taste good in the first place. As you can imagine, my list of good foods was starting to shrink, and my list of bad foods was growing exponentially. So, if you look hard enough out there, you can find something bad about any food. So there was very little variety left in my diet. I was eating the same thing day in and day out for all the meals. Because I was so scared to break any of those food rules and eat a food that I thought might contaminate my body, might make me less worthy, or my friends, my family, my coworkers might frown upon. And then that last one there is I was ordering for the eating disorder. If I went to the grocery store, I would inspect every label, I would check out every package, and then that would help me decide whether it could go into the cart or if it had to go back on the shelf. Same thing if I was at a restaurant. I wasn't ordering anything off the menu that I wanted to eat. There was no joy in food anymore. It was simply, I got to eat as healthy as I possibly can. And I think that's a great leeway now into that fine line that there is with nutrition. So around proper nutrition and disordered eating. Tiffany or Mark, I don't know which one of you would like to start the conversation there.
I don't remember which one of us are going to start it, but I'll just jump right in with this. Proper nutrition and disordered eating. It's really interesting. To have worked very closely with dietitians who talk about the confusion that some people have because often eating disorders and disordered eating start off as an attempt to be healthy, have control over keeping yourself away from unhealthy foods, things that will make your performance poor if you're an athlete or an artist, things that will lets you live long into your 80s or 90s or whatever, however long a person can live in a healthy manner. Having proper nutrition feeds the idea sometimes of disordered eating because people sometimes get into a space where they, how can I say this, where they overemphasize or believe things that aren't necessarily true and then fall into habits and places where their nutritional intake is not supportive of healthy eating, a healthy body, and then that leads them down a path toward disordered eating.
All right. And there's also that fine line there when it comes to exercise. And I know, Mark, you've got some more to share on that.
Yeah, I mean it's basically it's looking at your workout routine and what is um what's good for sport and what's good for health and what's kind of going overboard and becoming more pathologic. So what's the goal? Is it to challenge yourself and engage in activities that are enjoyable and energizing, or is it to alter your appearance and or regulate discomfort, i.e., using it as a maladaptive way of coping? Are you noticing incremental gains or are you noticing plateaus and decreases? That's sort of would show its face in red S or relative energy deficiency in sport, a diagnosis we haven't really talked about, but it's really a imbalance of the fuel in, fuel out equation, leading to a cascade of issues that you see in eating disorders. Is the mindset related to working hard and resting hard? Or is it about to move and the move to move and rest is unnecessary? Are you, if you miss a workout, are you concerned or distressed? Are you flexible or are you rigid? Are you resourceful and driven, or are you very compulsive and anxious about exercise? And finally, would you actually modify your exercise routine due to illness and injury, or are you training through it? So that's sort of where that fine line switches.
Yeah. And now I think this kind of leads into talking a little bit more about RED. So did you want to touch upon the consequences of underfueling?
Yeah, in short, so relative energy deficiency in sport is a new term. It used to be known as the female athlete triad, but then we figured out that not just females have eating disorders, and so it's an inappropriate phrasing. But it basically talks about how if you're not fueling yourself appropriately for the amount that you're going to expel from exercise, that can lead to an imbalance. And so there used to be something called unexplained underperformance syndrome or UUPS. God, we love acronyms in this particular talk, don't we? But that right there is when you're hitting all these plateaus, you're actually getting worse despite training your butt off. Um, if you're underfueling yourself, that can lead to loss of increased risk of injury, increased risk of viral illness, and you also actually aren't responding as well to altitude. Like if you like train in Denver and then you play on the East Coast at sea level, that training response isn't nearly as efficient. And you also, so yeah, you produce responsiveness to training and performance. But basically, if you get nothing else from this slide, it's that LEA, low energy availability, is due to overexertion and underfueling, whether or not it's intentional or inadvertent. So that's a point. So a lot of people who come in my office with reds don't actually have a drive for thinness. So that's that where it's not necessarily that they have any body image distress or not. They may actually just be simply not feeling themselves enough for what they're doing out on the court, pitch, whatever. And so just a simple meeting with their nutritionist or the dietitian. I've gotten not scolding, but the dietitian would be the one who's done lots and lots of training specific to this, especially sports dietetics, where they can just get kind of reconfigure how they're doing with their fuel in to be able to offset and not have any issues. But that's what we really like our dietitians. This right here, it's all about framing, and this is how you really can address the sociocultural aspect of the development of eating disorders. It's team messaging. And so, if you think about it, we're going at prevention. We want to make sure that we're talking about healthy eating, healthy exercise. So, culture can really play a part in this. If you're, I think that the phrasing metabolic injury is the most helpful way that you can talk about an eating disorder because it's tangible. If you're talking about how you like, for example, you're not trying to create bulletin board material by doing public weights, putting weights like on a bulletin board in a public area. So I always share with coaching staff that if for whatever reason they're in a weight-based sport or they're needing to be weighed, it needs to be in a private place, it's confidential, backwards facing, and it's like on a scale where they may even be agnostic of weights. They may not know it, but the person who needs to know the number can get the number so it can be monitored. Um, Role modeling is really good. So basically, remember I was talking about how they can spread like wildfire. If you see something, say something. So like we point out, we don't talk about body weight and shape in this particular atmosphere. That could be helpful. And then also the LEA, like just providing education that that's a real thing and that it can become its own problem. Because if you may not have cognitions, but if you've been running in a low LEA this whole time and you're kind of becoming used to what that body now looks like, when you try to weight restore, you might notice that you actually do have body image distress. And so that's actually why ARFID, now we're going really in the weeds, why about 10% of the time it actually develops into anorexia nervosa as they weight restore. That body image distress and those cognitions were actually there the whole time, but masked by being underweight.
All right. And then I think just a really great thing as we start to wrap up here is to remember a holistic approach to health, touching back upon what we were talking about with orthorexia, but this goes with any type of eating disorder, is that it's got to be a holistic approach to health. I think nowadays we've prioritized physical health above everything else. When I go out to different colleges and stuff, I ask them what comes to mind when I say healthy, and it's always something related to diet and exercise. But the truth is, there's so much more to our well-being than just that. There's the mental health, the spiritual health, social, emotional, environmental. There's many different healths, and all of this has to be a part of the conversation. So really taking that holistic approach rather than prioritizing one over everything else. And now, I mean, what do we do if a teammate, if a friend, if a loved one is struggling and we don't know really how to approach that conversation? Like Mark was saying, it's really important to differentiate between the person and the eating disorder, because they can become so intertwined that it's hard sometimes. But if you're talking to somebody that you're concerned about, the first thing that we recommend at Anid is to make a plan. Learn as much as you can about eating disorders. Identify what's a great opportunity to maybe talk with this person. Be mindful of the space in which you're doing it in. Who's going to be there? Where's the conversation going to happen? Think about all of those things ahead of time so that you can approach it with the least amount of hostility or tension possible. Remain calm. Understand that that first conversation might not go the way that you want it to, but just be there to listen. That's the most important thing. I'm one of those people that's a fixer. When I see somebody that's struggling, when I see somebody in pain, I want to jump in, give them a million solutions, and tell them how to fix it. But that's like the worst thing that you could do with an eating disorder because you've got to be there to listen to the person and help them work through that. So just giving them the space. And then rather than saying, well, you got to go do this or you got to go get help, suggest it instead. Offer it as a solution. Understand they might not take it that time. You can always come back at a later time and talk some more. And one of the things that I didn't have on there, but I always say start those conversations with I statements. Don't go in with you statements and say, you're doing this, you're doing that. Speak from your experience, speak from what you're seeing, speak about how it's making you feel. Because if you go in with you statements all the time, it can feel like you're accusing the other person, and it pushes them in the opposite direction. As we wrap up here, Mark, you've got an important reminder that I think really sums it all up when it comes to talking about eating disorders in athletes.
Yeah, again, invisible injuries here. Metabolic injury, think of it as a tendonitis of physical injuries, and that if you don't do anything about it, it's not exactly going to go away. It's just going to linger and actually get worse. And so there are, athletes may experience grieving that they might actually, temporarily or permanently lose their sport. And so that basically because of the eating disorder itself. Again, it's a blameless illness here. That being said, there are identity aspects that need to be dealt with. And so when someone weight restores, a part of the team actually is we actually use a mental performance coach from my old eating disorder team within sport, where that person's job was to help with doing some mental skills training for helping either return to sport or healthy retirement from sport once they're rate restored and can actually deal with the cognitive aspect of recovery. Um, Sometimes when their athletes are dealing with an eating disorder, they may have limited interaction with their teammates and that they're having to go get treatment. So whatever you can do to maintain that socialization, a sense of normalcy, also super important about how athletes can maintain or could benefit from being in a group of like-minded individuals that would be really helpful for recovery. And it takes patience, as I mentioned, the tendonitis aspect. And then, yes, there is uncertainty about regaining that prior level of performance, but it's unhelpful to talk about in the moment when they're needing to recover. That identity work and all of that drive that was actually very productive in some ways, but then the eating disorder glommed onto that drive and took it in a very unhealthy direction. That there can be a purpose for that later in life. But we have to kind of talk about the here and now, which is weight restoration and stopping either the up and down of a binge purge cycle.
All right, awesome. And Tiffany, did you have anything to add?
Yes, and one thing I also wanted to piggyback on Mark's point or Dr. Allen's point is also be very careful about what types of influences you allow yourself to be susceptible to or to be in touch with. For instance, you can look at things on social media. You can look at various types of things that can be really helpful and supportive. And then there's also that like little weird pathway in the internet that leads to all kinds of unhealthy things, like certain types of websites that are pro eating disorder. Be very careful with ingesting and interesting word and consuming that type of information because it can derail your progress.
Yeah, and I love that, Dr. Allen. Look for partners in recovery, not partners in illness. So healing does happen, and ANID is the organization that I work for. Tiffany's on the board, and we are rooted in peer support. So if you are looking for a partner in recovery, that's kind of what our organization's all about. All of our support groups are led by individuals who have lived experience with an eating disorder. I'm excited to lead the men's group. We also have a warm support line that's available. If you've got any questions about eating disorders, if you're concerned about someone else, if you're concerned about yourself, there's a treatment directory. We've got resources for loved ones, educators, athletes, you name it. So if you need anything at all, it's virtual, it's free, it's accessible from anywhere. So definitely feel free to reach out to Anit if there's anything that we can ever do as far as peer support and helping anybody in your life find that community for healing. So with that, I think we've got a couple more minutes here for questions. I did see one question that came in that's really good, and I will throw it over to either Mark or Tiffany, whichever one wants to answer it. But can any therapist help with eating disorders, or are there specific professionals that people should go to?
That we could
I'll just
both offer. Yeah, go ahead.
I was going to say, I feel like we could take two different, Tim, you start, and then I'll hop in.
I would say there is specific training after you can do your generalist training that allows you to specialize in eating disorders work. So I am a certified eating disorder specialist. So within counseling, within psychology specifically, yes, there's additional training that can be done. I have worked with people who have the same generalist training and avoid working with people who have eating disorders because they don't feel like they have a good understanding that would be helpful and facilitative to that person's care. So if someone has a specialty, they've done additional research, it's probably best. They may have a better understanding on how to work with a person who has an eating disorder and understand the standards and the best practices for care to help that person through recovery.
Yeah, all I would add is that the CEDS, the CEDS, Certified Eating Disorder Specialist, that whenever you see that, that means that person's done a lot of training and a lot of mentorship in in the specific area. At least on the medical provider side of things, there's not really an eating disorder fellowship per se, as in now, even though I think there's a lot of interest. Um, Within psychiatry, you do a rotation during your general residency within eating disorder work, like on an inpatient eating disorder program or residential level of care. as well as some outpatient. But you really, in order, if you have an interest in it, you cut your teeth by jumping into it and learning on the fly from people like Tiffany and myself. I mean, I my first job at a fellowship was actually on an eating disorder program, and I was basically told, "Look, Mark, you got to get a research project on ARFID because it's a brand new diagnosis. Came out in 2013, and you're going to give talks on it. So good luck." And then also you're going to become FBT trained, so family-based therapy on anorexia nervosa in adolescents. And so I learned it was trial by fire, but I will say it is worthy of the work. It's the most complex and multidisciplinary diagnostic cluster within all of mental health, and it certainly has the second highest mortality rate. So it's really needed. But it's through talks like this to break the stigma, to sort of share things. I think it's really valuable.
Awesome.
And
Thank you
Anna,
guys. That
oh,
was amazing. Yeah, I'll jump to Anna in a second. I just want to thank all of you for sharing your expertise with us. And also, Jason, thanks for sharing so much about your personal journey. I want to be respectful of everyone's time. So if you need to jump off right at 8, by all means, go for it. But maybe if it's okay with our guests, we can get to maybe one or two more questions quickly. So Anna, if you want to jump in quickly with your question.
Yeah, so I was just wondering, like, so after you have a one-on-one conversation, what is the best way to go about telling like coaches and trusted adults? Because I know that for like where I'm at school, like it's very important that we have like, a support system and things like that. But not only with that, like I also don't want to be the only person that is aware. So like what is the best way to like go and tell other people without it seem like, oh, well, she's dealing with this, and this.
yeah, I would say from the conversations that I've had, one of the best ways to approach it with a coach or a counselor or somebody at school is to approach it from curiosity. And maybe, it's not like you're going in and you're saying this person has an eating disorder and they need to be talked to right away. I've seen some things I'm concerned about. Would you kind of join me and keeping an eye on things and maybe monitoring? So that it's more of from a curiosity questioning perspective rather than that, again, accusing somebody right away. And then at least you're not alone in it. Then there's somebody else who's kind of keeping an eye on the situation too. And it doesn't maybe feel like they're being ganged up on, or all of a sudden everybody's coming down on them all at once.
Thank you.
Maybe we'll grab one more from the chat and then we can also reach out later with questions if folks have other questions for the panelists. Um, this was an interesting one. When does picky eating become disordered eating or an eating disorder? And I guess kind of similar, it sounds like, to the conversation we were having about where's the fine line?
Yeah, so that's really that fine line with ARFID, I think. Tiffany, did you want to touch on that one?
I was actually going to say that when it looks like
Yeah.
avoidant restrictive food intake disorder, and it actually impacts your ability to function in your day-to-day life and live your life the way that you typically would in a way that feels healthy and meaningful, that might be a time to consult with somebody and talk to somebody about what exactly is going on to see if that line's been crossed. It's okay to be a picky eater. It's not okay, of course, for your body to not receive the nutrition that you need to keep yourself functioning in a way that is good and healthy for your body.
Yeah, no, it's wild. There you can develop vitamin deficiencies as well, not just you know, being way underweight. I actually worked with a kid who had gotten a vitamin A deficiency and went blind due to restrict such a narrow range of foods. And so a lot of the work with ARFID is learning how to slowly but surely expand food range, so with textures and colors and just you don't want a kid just to eat chicken nuggets and French fries, which was all that kid kind of was doing. I think it really got all the way down to his French fries. But it can be pretty scary.
And it can be scary for the person too, to even expand into that. Thank you, Dr. Allen, for sharing that. I had a client once who would only eat things derived from chickpeas. That's a really restrictive grouping of foods.
All right. I think, Jason, thank you for getting to some of our other questions in the chat. We'll wrap it up there. Thank you again to all three of you. It's been a great conversation. We're so glad that you were able to join us tonight.